All right, so now that's all the initial visit. What happens in follow-up visits, and how often are they? Typically, as long as everyone remains healthy, follow-up visits are monthly until week 28, and then every 2 weeks till week 36, and then weekly until delivery. At the follow-up visits in the history part, we want to ask about any new symptoms, problems, or concerns, ask about their emotional state. So what has changed since the last time they were there? The physical exam, vital signs need to be done at every visit. The blood pressure should be done in the same arm each time with the patient seated with uncrossed legs. Weight is done and weight gain is evaluated. And we're looking primarily for sudden increase in weight gain because that can indicate fluid retention, which can be due to preeclampsia. We look for the presence of edema and where that edema is and how severe it is. We want to do an abdominal inspection, measure the fundus. When that patient, especially from the second trimester on, when they're supine for that abdominal inspection, we need to put a wedge under the right hip to tilt them off of the vena cava, and we want to measure the fundus. Labs that are done at every visit, a urine is done for protein, glucose, nitrites, and leukocytes. We're looking for protein preeclampsia, glucose, diabetes. It's not uncommon to spill a little bit of glucose in the urine in pregnancy, but it shouldn't be a consistent finding. Nitrites and leukocytes can indicate possible UTI. At around 11 to 14 weeks, there's some screening for chromosomal abnormalities and for some other complications that may involve a blood draw looking for some specific chemicals associated with pregnancy, and also an ultrasound for nuchal translucency. Around 15 to 20 weeks, there is a blood draw for some really specific chemicals that may indicate either neural tube defect, chromosome abnormalities, and some other issues. And that actually started with just an alpha fetoprotein, and then they added a couple of things, and it was a triple screen, and then it was a quad screen, now it's a penta screen. So they keep adding things that they screen, and they combine that with that nuchal translucency that's done around 11 to 14 weeks to get an idea. These are all screening exams. If abnormal results come back, they're not diagnostic of anything, but they indicate that they may need further testing. And that may be, there are some things that indicate Down syndrome. There are some things that indicate neural tube defects. There's some things that indicate some other chromosomal abnormalities. So those are screening, and they are done for everyone. And then if an abnormal result is returned, that patient comes back for further testing. It's really important that patients understand those are screening tests. Okay. Around 18 to 24 weeks, an ultrasound is usually done for fetal anatomy to make sure that all those systems have formed correctly. 24 to 28 weeks, a glucose screening of some kind is done, because this is when we'll start to see gestational diabetes develop. At 28 weeks, remember 28 weeks is when we get that dilutional anemia. So at 28 weeks, we usually recheck and see, are they anemic enough to need some intervention? If they haven't had a type in RH yet, that's going to be previously done. If they're Rh negative and they're not sensitized, they don't already have antibodies against Rh positive blood, then a dose of RhoGAM is given at this time. And RhoGAM is artificial antibodies, so it prevents the maternal blood from making antibodies against the fetal blood if there's a difference in Rh status. So Rh women get RhoGAM at about 28 weeks. At 35 to 37 weeks, women are going to be swabbed for group B strep, and that's usually a vaginal swab. Sometimes they'll do a vaginal and a rectal swab. Fetal assessments that might be done from about 12 weeks to delivery. They measure fundal height. From about 20 weeks on, that's usually within 3 centimeters of the gestational age and weeks. So 20 weeks, it should be around 20 centimeters. 24 weeks, it should be around 24 centimeters. Fetal heart tones can be heard usually beginning around the end of the first trimester. So they'll try to do that. They don't usually get worried until it's a little bit later if they can hear it. Gestational age estimation is kind of redone at each visit based on any new data. We're looking for signs of potential complication. In the first trimester, what are some danger signs? We want to be aware of severe vomiting. But nausea, vomiting is common. Being absolutely unable to keep anything down, vomiting to the point that we've got tears and we're having to vomiting blood, those things are not normal. Okay, so if vomiting is not allowing them to retain anything, any fluids or food, that needs to be addressed. Chills or fever can indicate infection. If you don't know where the infection's coming from, check the urine. Dysuria. When we think about a UTI, frequency and urgency are common symptoms. Well, those are also early pregnancy changes. And so sometimes people won't notice. And if they don't have that pain and burning, they might not realize they have a UTI. So we're looking for chills, fever, feeling bad, and we're going to check the urine. But also if they report burning, we need to assess urine. Diarrhea, abdominal cramping, and bleeding. So all of those are potential danger signs in the first trimester. In the second and third trimester, they're still having a lot of vomiting. That needs to be assessed. A sudden discharge of fluid before 37 weeks could be amniotic fluid, vaginal bleeding, severe abdominal pain, any signs of infection, a severe backache or flank pain can be kidney infection, changed or absent fetal movement. So if they've been feeling the baby moved and that's different, they're feeling it less, that needs to be assessed. Contractions, cramping, or pressure before 37 weeks. Visual disturbances like seeing spots or flashes of light, major red flag for preeclampsia. Severe, frequent, or continuous headaches, muscular irritability or twitching. Again, that can be preeclampsia. Seizures are emergency. They need to be told. If you have seizures, someone needs to call 911. Epigastric or upper abdominal pain can be associated with preeclampsia. And then we look for glucose in the urine or positive glucose tolerance tests. Both of those would indicate gestational diabetes. There are some variations in, we've been talking about what's standard care. There are some variations. There are some people that need things to be a little bit different. We want to make sure that we're giving culturally appropriate care. Adolescents might need more teaching, and they definitely need more teaching usually, but they might need more close monitoring. There are some things that they're a little bit higher risk for. Women older than 35 years might need a little bit more frequent monitoring because there's some risks that are a little higher. Multifetal pregnancies definitely need more monitoring because there are several risks involved. Okay, next section is going to be about prenatal education.